Welcome to EMS Office Hours. This is Jim Hoffman, and these are your Monday Minutes. Today, we're going to continue on with some trauma, guys, and get into head trauma a little bit. And this is a little bit of a longer video because I want to try to cover as much as I could here when it comes to head trauma and giving these key elements. If you like this stuff, guys, be sure to go check out TurboMedic and get yourself a free insider membership. It's at emsseo.com/insider. So, of course, I always like to start these out just as a reminder to tell you why this stuff is important. And again, I've said this before, but it's not just for exams. Yes, this is key information to help you pass exams, to remind you of things you will often see on many EMS exams. But it's also to help you build your knowledge base so that you can make better clinical decisions, write better reports, and interact more effectively with other healthcare providers. Okay, so just keep that in mind. All right, so I'm hoping that if you see something in these videos, these Monday Minutes, that if it doesn't ring true to you, if it's confusing, you think I've made a mistake, that you'll go ahead and crack open your textbook and do a little research on your own and really go ahead and hammer that home and build that knowledge base and move your knowledge needle just a little bit. So let's get into today's stuff, guys. We talk about head trauma, and you have to always assume spinal injury with any sort of head trauma. Right now, these days, the care for that and how you treat for that and whatnot will vary, okay? We're not so much into the longboard and collar like we used to be. But follow your local guidelines, and no matter what, you should still assume a spinal injury, right? Otherwise, don't make them move around. Don't be jerking their head back and forth, things like that. So just assume that injury is there. You want to control the bleeding, as with any injury, but you want to use gentle pressure when we talk about controlling bleeding with a head injury. When we talk about open versus closed injuries, okay, you have a break in the skin, you have no broken skin, right? An open skull fracture, of course, is going to have a break in the skin, whereas a closed one will have no break in the skin. The same is sort of true when we talk about a depressed skull fracture versus a non-depressed. With depressed skull fracture, the fragments of the skull is going to be forced inward, whereas a non-depressed skull fracture, the fragments kind of retain their normal alignment of the skull, but you still have the break going on there. Okay? Now, when we are assessing head injury patients, you want to find out the history of what's going on, right? But one of the most important things is to think about the mental status of the patient. All right? Looking for confusion, looking for lethargy. Now, I wrote here ongoing evaluation because with head injuries, the patient might present to you initially as being alert and oriented ×4. However, as the head injury might develop and other things might be going on, you can't see because it's inside their head, the mental status can start to deteriorate, right? So always making an ongoing evaluation with that. And we talk about our pupils and are they sluggish to react, right? Obvious injuries, things like penetrations, impalement, deformity, all right? Keep all this in mind, stuff that you should be looking for to try to give you clues as to how severe the injury is or how severe it can be. All right. Now, some more assessment tips here, guys. When you look for blood coming from the nose or the ears, or look for that cerebral spinal fluid. All right. Do you see it coming from there? All right. These are indications that something else is going on. Raccoon eyes. I'm sure you see this in many, many textbooks. A lot of times for us in EMS, we don't see it unless the patient calls the next day, right? Because this doesn't usually appear till maybe 12 hours or so afterwards. Now, battle sign, this is also a later sign, also maybe 12 hours after the initial injury. but it's kind of important to kind of know what's happening, right? This is a affecting the occipital bone, a basilar skull fracture. So again, these patients might present a little bit later, but you want to go ahead and monitor them and identify recent changes in their mental status. We go back to the history of what's happening, the history of that patient, and how their mental status has either changed, deteriorated, or is it the same since the injury. Okay? Now, guys, talking about brain injury itself, all right? This is when you talk about things like concussions, contusions, other obvious injuries, open injuries, hematomas, and of course the hemorrhage, right? The bleeding going on. Now, what are some of the signs you're looking for? Well, they could have a headache. That could be a very common sign. Again, evaluate the pupils. Are they dilated? Are they unequal? Are they non-reactive? And what's their mental status? Again, guys, I want to hammer this home because the mental status is key, right? Did they have a loss of consciousness? Do they have any kind of amnesia, whether it's retrograde, where they don't have any recollection of the events before the injury, or is it antegrade amnesia, where they don't have a recall of any events immediately after them coming out of being unconscious? And think about paralysis. Do they have hemiplegia, where they have paralysis on one side of the body? Is it paraplegia, where it's on just the lower extremities? Or is it quadriplegia, where they have the paralysis to all four of the extremities? Or did they perhaps start out with no paralysis and then have developed into hemiplegia, where it's one side, and then maybe into now the low extremities, or maybe the low extremities and then into all four extremities? Things to keep evaluating, guys. And look out for the posturing. This is the key things here, guys. You'll see this a lot in exams. Whether you got the decorticate posturing, where the arms are going to flex in towards the core. All right? And decelerate posturing, where the arms are extended and they're rotated. All right? Now, the easy way I feel to remember the difference between these two is that when you talk about decorticate posturing, the arms are going in towards the core to protect the core. All right? And then, of course, the opposite would be the decelerate posturing. All right? Just for me, that's an easy way to remember those two things, and I think you'll find it easy when you're taking exams and things like that and assessing your patients. That'll ring bells to you of what's going on. And that's also important to note as well when we talk about Glasgow Coma Score, right? Okay, now I want to get into the ICP, right, or that intracranial pressure. And this is the pressure that's within the intracranial compartment of the head, right, inside the head. And this increases, that can lead to further brain injury and eventually death. So you need to be aware of this happening and what to look for if it is happening, when it's rising. Okay? Their level of consciousness, their responsiveness is going to drop on you. Like I mentioned before, that paralysis we talked about will start to progress. You'll get that progressive paralysis. You will have vomiting. But more often than not, it will be projectile vomiting. And when you see it, if you've never seen it before, when you do, you will know the difference between regular vomiting and projectile vomiting. Back to the pupils, right? The windows to the brain, you might hear that called sometimes. They will be unequal, right? You'll get the Cushing reflex, or that triad, right? And this is a later sign, but you're going to get a high blood pressure, especially systolic, an increase in respirations, and a decreased heart rate. So you get respiratory rates up, blood pressure's up, but the heart rate will be bradycardic. There will be a decreased heart rate. And look at your Cheyne-Stokes respirations, guys. This is an earlier sign, all right, that something is going on. It's a periodic breathing, where it'll be very, very rapid, and then it'll be absent. Very, very rapid and then absent. And the spaces between them and the period will lengthen and differ. You start seeing this, it should be a bell going off that the patient is having some ICP happening, and you need to act. Okay? And mainly that acting is going to be rapid transport to the hospital. A lot of the stuff we talk about when we talk about management of head injury patients, there's not a lot we can do besides supportive stuff. Of course, you want to maintain their oxygen, right? Securing the airway, maintaining the perfusion, protecting the spine. Like I said, of course, you're going to follow guidelines, your local protocols for that, right? Elevate the head. A lot of guidelines state that elevate the head to help alleviate the pressure, right? ICP that might develop. And allow leakage of CSF or blood from the ears or the nose, right? They tell you to kind of just gently cover the ear, cover the nose, just to allow that drainage out of the skull, out of the intracranial compartment. Now, one thing I wanted, and I'm going back to this again, note the mental status changes. The history, the current history of the mental status. When they woke up, what is reported to you before you get there, what you find when you get there, and how the patient changes or stays the same, improves, worsens, etc., while you have them in your care. Document their current level when you get there, the previous loss of responsiveness, the ongoing memory deficits. We talked about amnesia in a previous slide. All this stuff ties in. So when you give your report to the emergency room and the trauma team, this is going to be some of the key things they're going to be looking for. So note it so that if you forget it, you can go ahead and look it up on a notepad or whatever you use, so you can advise the staff, and when you document appropriately what was going on with the patient. Now, of course, guys, we talk about the Glasgow coma score, coma scale. It's important to know this stuff, guys. You hear a lot of less than 8 to intubate, right? Because knowing the Glasgow score, guys, is important. All right, because it's going to help you when it comes to evaluating the patient's mental status. All right, so get to know the GCS, understand it, remember the numbers, so that when you're giving reports and you're assessing the patient when it comes to trauma, that is what they really are going to be asking you. Okay, a lot of trauma systems want to know the patient's highest heart rate, lowest blood pressure, and GCS. Okay, so if you need a card, you need to put it on your phone, you need to memorize it, do that so that you know the GCS. Okay, and guys, again, I'm putting a slide here about Turomedic and Turomedic Insider. This is a free membership, guys, inside Turomedic. There is a wealth of information here, including practice exams, including some training there. There is digital content for you to download to access online, hours of audio and video, and of course exclusive access to the members only Facebook group there as well. Guys, go check it out. It's at emssto.com/insider. I think you will like it when you get there. Hopefully it will motivate you to become a premium member there and get even more content, including the weekly live training and coaching that goes on there. All right, I'm going to end it there, guys. I hope this helps you out. Please contact me if you have any questions. You have some Monday Minutes of your own. You can contact me at contact@emsofficehours.com. And, of course, visit emsofficehours.com for the latest podcast episodes and other Monday Minutes. If you're watching this on YouTube, please hit the subscribe button on the page and subscribe to my channel for other Monday Minutes and other videos that we do here, including Facebook Lives and things like that, that I think are all going to help you when it comes to understanding content, succeeding in EMS, and moving the knowledge needle just a little bit in ways that will help you be better at EMS. All right, that's it for me, guys. As always, I am Jim Hoffman for EMS Office Hours in the Monday Minutes. Stay safe.